Welcome to today's webinar, Ask the Headache Specialist, hosted by Everyday Health and Migraine Again. I'm Paula Dumas, Editor-in-Chief of Migraine Again and Editor-at-Large of Everyday Health, as well as a lifetime migraine warrior. So if you're a person with migraine or headache, a caregiver, a coworker, or someone who lives with someone who does, you're in the right place. It's Migraine and Headache Awareness Month, and so today we're going to welcome two leading experts to our conversation. And Migraine and Headache Awareness Month is not just for people with migraine and headache to learn more. It's also for us to come together to raise awareness for people who don't have the disease and who might not understand how disabling it can be. Policymakers, employers, friends, family, healthcare professionals, everyone. And you might feel like no one understands what you're living with, but I assure you, you are not alone. You are in good company. So you're going to learn today some things that you've probably never heard from your local doctor. And we're honored to have two top doctors with us today to answer your questions. So keep them coming. And if you haven't done so already, send us your questions in the chat and we will do our best to get to as many as we can. You can also share this link with anybody else you know who might be interested in learning a thing or two about migraine and headache. So sharing is caring. So we're going to explore your questions about what causes migraine, how long it lasts, how it affects our minds, our work, our relationships. And we invite questions about treatments too, the latest new therapies that are proven to prevent and relieve migraine attacks. I'm pleased to introduce our experts, Dr. Andrew Charles, who is the director of the Goldberg Migraine Center at UCLA School of Medicine and the vice president of the American Headache Society. And he's also the author of a new series called Ask the Headache Specialist on migraineagain.com. And Dr. Allison Young is board certified in psychiatry and an adjunct professor at the NYU School of Medicine, where she directs a curriculum on lifestyle medicine and mental health. So Dr. Young and Dr. Charles, welcome.
Thanks, Paula.
We are glad to have you here, and we're going to dive right into the first question about what causes migraine. So Zainab asked us on Everyday Health Instagram, how can I stop anxiety-related chronic tension headaches? Dr. Charles, you want to start with that one?
Sure, be happy to. So good question, sort of a tough question. My first response would be, though, to ask, why do you think you have tension type headaches? Where did you get that diagnosis? As a migraine specialist, we really are seeing that many people have received a diagnosis that isn't necessarily correct. And I would, again, question the diagnosis of tension type headache. So if you have any light sensitivity or nausea associated with your headache, or if the headache is severe enough to take you out of your normal function, then the odds are that this is migraine and not tension type headache. And the reason that that's important, as we'll be talking about, is that there are some very different treatments that we have for migraine. So it's key to have a right diagnosis. I would also just quickly say, too, that anxiety is comorbid with migraine, meaning it goes hand in hand with migraine. And so that's kind of a flag to me that tells me that maybe you have migraine and not tension type headache.
Interesting. Dr. Young, do you see that a lot in your practice, the link between anxiety and migraine?
Yes, for sure. And anxiety alone can cause a lot of different physical symptoms, headache being a common one, stomach issues being another really common one, as well as a few others. So it's possible that anxiety is causing a headache, but it's also positive, like Dr. Charles said, that it's not a tension headache, it's a different diagnosis, and it is going hand in hand with anxiety. I think anytime you have a physical symptom that is related to anxiety, that tips me off that your anxiety is bad enough that you think it could cause a physical symptom. And so I think the best way of managing that as well is to address that anxiety. So in addition to making sure you have the correct diagnosis for that headache, also seeing a mental health specialist to make sure that you have the tools to manage that anxiety.
Excellent. So this one is sort of related. Someone says, I have a stressful job. Is migraine caused by stress? And will quitting my job help? Dr. Charles?
Yeah, so we commonly hear about stress as a trigger for migraine, and it's either the acute stress or the letdown from stress. So commonly people describe when they relax after a stressful situation or a stressful day, that's when a migraine attack actually begins. Um, but having said that, I will say it's important to emphasize that stress is not the cause of migraine. Migraine is an inherited disorder. It's in your genes. It involves very distinct physiology and chemistry, and it's something where certainly stress can influence the frequency and severity of migraine and how you respond to it, but it's not actually the cause of migraine itself.
And Dr. Young, do you find that when someone has a lot of stress in their life, eliminating that source of stress is automatically going to make their symptoms better?
So I think this is kind of a loaded question that could be unpacked a little bit because it's hard to live a stress-free life. But I like to categorize stress as kind of a positive stress and a negative stress. Positive stress is challenges we're presented with, but going through those challenges bring us closer to our authentic selves, bring us closer to our value system, and overall make us feel fulfilled. Negative stress are those types of challenges that doesn't come with that positive aspect. And so I think whether it's for your physical health or your mental health, it's really important to minimize the amount of negative stress you have in your life, but then learn to manage the positive stress and have the coping skills to manage the positive stress. And so I think it's figuring out one, what kind of stress is that job for you? And what can be done about that over time. Obviously, quitting a job can lead to financial stress, which is another form of stress that can impact you. So I think getting to know yourself, getting to know your values, making sure that you're minimizing negative stress, increasing the coping skills to manage the positive stress. But I think the expectation to live a stress-free life just isn't possible, but not all stress has to be inherently negative.
You're just swapping one stress for another, it sounds like.
Yeah.
So we've got a couple of questions about weather. Both Kendra and Joanne are asking Dr. Charles, can anything be done to prevent weather-related migraine? What's the connection there?
Yeah, it's an interesting question. Weather changes are also often identified by individuals as exacerbating factors for migraine. And there's a little bit of evidence, not a lot of evidence for that. There's some sort of extreme weather changes like the Chinook winds in the north or the Santa Ana winds. There's some evidence here in Los Angeles that those can be problematic. And we also know that a migraine can be triggered by changes in barometric pressure that are significant, like going to altitude, for example, is a very common migraine trigger. So clearly there's a mechanism that's involved, but we don't really know what it is. We have some theories, and so we have some approaches that we are thinking about in terms of modulating migraine that might be triggered by changes in barometric pressure. But obviously, we can't control the weather. And I do have patients. This is sort of related to the quit your job. I have patients who actually think if they move, it will help their migraine. That rarely happens. So what I guess I would say would be in tune to the early signs of migraine attacks that might be triggered by weather and intervene as early as possible with appropriate therapies. And that's pretty much the best that we can do at this point until we have a better understanding of how it is that that barometric pressure and weather change actually causes migraine.
Yeah, I find that if I dial down my exposure to all other triggers when the weather is coming in or changing, that for me, that's one way of managing something I can't control, which is the weather, by modulating the things that I can control and the other triggers. Dr. Charles, can you comment a little bit more on the difference between causes and triggers?
Yeah, so it's a subtle distinction, but again, going back to the idea that migraine really is an inherited disorder that involves complex changes in chemistry and activity of the nervous system. And that's what we would think about as a cause of migraine, those fundamental mechanisms that are occurring when a migraine attack takes place. Whereas a trigger is something that basically would be one thing that layered on your propensity to have migraine because of your makeup can actually be something that brings one on. The problem with the whole attention to triggers is multifold, as we've talked about before. One is that what is a trigger sometimes isn't always a trigger. I mean, and we know this, people who identify, for example, eating chocolate as a trigger. But when you look prospectively at people who identify chocolate as a trigger, it turns out that it really isn't a consistent trigger. That's number one. But the second sort of the dark side of focusing on triggers is blaming oneself for an attack occurring. And this happens very, very often where people will tell me, well, I had a migraine attack because I did this. And I say, no, it's not because you did that. That might have been a factor involved, but it's because you have migraine that you had a migraine attack. So don't, while it's important to obviously pay attention to triggers, it's also important not to blame yourself when an attack occurs and think that it's something that you did wrong. And that's also, I would say, I'm going on a bit long about this, but it's an important point. It's also something that some providers spend too much time focusing on as well, actually sort of, again, shifting the blame to the patient rather than to the actual disease itself.
So bottom line, it's not your fault, it's in your genes.
Yep.
Okay, fantastic. And one last point on what's causing migraine. We've got a couple of questions about what is happening with sinus migraines. What can you do for sinus migraine? Jamie is asking.
We wouldn't use the term sinus migraine. We would use the term migraine. It's interesting, the whole notion of sinus headache was actually introduced by the manufacturers of one of the decongestants. That term didn't even exist until it was, I believe it was Dristan, the decongestant, was the people who basically created that term. So the issue, it's a very important one. So migraine can commonly occur in the maxillary region pain or in the frontal region where people associate with sinuses. As we just talked about, migraine can be triggered by changes in barometric pressure, which often leads people to think that it's a sinus issue. But the fact of the matter is that sinus pathology as a cause of headache is actually pretty uncommon. And it's very, very easy to distinguish sinus or headache related to sinusitis compared with migraine. So if you have a headache that's there all the time, it's worse when you bend over, you have congestion, it's there continuously. Maybe that is a sinus due to sinus disease. But if it's an episodic headache where you basically have 2 or 3 days of pain and then in between you're feeling fine, that's not related to sinus disease, that's migraine. So very important to understand that sinus disease doesn't cause headache that often, and the overwhelming majority of people who think they have what has been called sinus headache actually have migraine.
I have friends who absolutely swear that they have sinus headache, and as they go through their symptoms, I'm like, nope, that sounds like migraine.
Yeah. So
it's pretty common, right? All right, well, I'd like to pivot and kind of move on to whether migraine goes away. Sue gave us a question. She said that there's a percentage of data that shows, even if minuscule, that migraine goes away. A girlfriend suffered from migraine long before I did, and after years, poof, they just disappeared. No rhyme or reason why. Dr. Charles, why does that happen?
Yeah, the clinical course of migraine is quite variable from individual to individual, and for some, fortunately, they can go into remission. So generally speaking, we don't think about it as being completely gone, but really, the term remission, I think, is appropriate here. The typical course of migraine is that it begins in adolescence, although it may begin in childhood. Prevalence is about equal in boys and girls, and then when you hit adolescence, it rockets up and it becomes 3 times as common in women as men. And then with menopause, and I think this is a question coming up, there may be a flare of migraine around the time of menopause, but typically after menopause, migraine becomes much less frequent, and it may in fact actually go into remission. It still remains more common, interestingly, in women than men after menopause, but that is something that many women especially can look forward to, is that as they get older, typically migraine frequency will decrease, and again, in some cases, will just disappear.
Yeah, so many people on our team, because we have a bunch of migraine advocates who are also working on Migraine Again and on the daily migraine, are kind of waiting for the day that menopause happens and suffering through perimenopause, because it tends to get worse during those years. And for me personally, I was expecting that migraine would go away when I hit menopause, and it didn't. And that's a drag.
Yep. Yeah.
Yep.
So I don't want to make promises, but I think it's the possibility is there, and certainly again, generally speaking, attacks become less severe, but still, it certainly may persist. And we have, I'm sorry to say, we do have people in their 80s who are still having migraine. So it really is something that it's not uniform, that it basically goes away.
That's right. Jeannie is watching today, and she's 70 years old and has been dealing with them since she was 19. So it does last for many, many people. So I'd like to move on to some questions for Dr. Young about how migraine affects our minds. And things like memory and grief and anxiety are all factors. Let's talk about anxiety first. We've got a question about people who have heard that anxiety is a symptom of migraine. And how do I know if I have anxiety?
Yeah, so as we kind of talked about, anxiety and migraine have a bidirectional relationship. When I say this, I mean having anxiety can definitely help trigger migraine, or at least increase the frequency of migraine or the duration of your migraine. But also having migraine is a risk factor for developing anxiety. So it's kind of this bidirectional relationship. Anxiety comes in different forms. So some people think of anxiety more like an anxiety attack, which is a panic attack, which is this surge of kind of impending doom, fear, restlessness that's accompanied by physiologic symptoms of feeling kind of like I'm going crazy. And then it kind of dissipates. But then what's left for a lot of people is this fear of getting another one. And then there's a more generalized anxiety, which is just daily worry. And that's what most people find as excessive, right? We all worry, but this is worrying all the time, difficult to control, difficult to reset your mind and focus on something else that lasts 6 months or more. So I think the big thing to wonder, because obviously mental health exists on a spectrum, having some anxiety and having some feelings of panic when you're really nervous about something is normal. And so to figure out where it is on your spectrum, asking yourself how much it's affecting your life. If you find that you're worrying or consuming a lot of your daily experience with worry, and that it's really impacting you, then likely it is a problem that could be addressed with a mental health specialist.
That's great. Dr. Charles, anything to add on anxiety?
No, it's just that it's extraordinarily common in those with migraine, as Dr. Young mentioned, and it really is an issue that, as she said, needs to be dealt with separately in different individuals. So, as migraine specialists, we will focus on the migraine aspect of things, and sometimes, if you get migraine under control, that will have a secondary and ancillary benefit on anxiety as well, but not always. So, again, they may be parallel issues that are interacting with each other, and really, in some cases, it's very important to deal with both individually.
Well said. So we've got 3 questions related to memory. And some people believe that some of their memory issues or brain fog issues might be caused by medication. One question here from Angie says, I've had migraine for 30 years now, and I'm dealing with memory loss and fatigue. And her treatment has stopped working, and she feels like she's out of options. Any suggestions? Dr.
Is
Charles?
that okay? I'll take that one. Yeah, so these are very important issues. So one thing it's important to start out with is the notion that this cognitive dysfunction, or what people describe as brain fog, which may be memory problems or word finding problems or difficulty concentrating, those are extremely common symptoms of a migraine attack. So they basically, for some people, actually, the most disabling symptoms of a migraine attack is the inability to be cognitively functional. But then also, when people begin to have chronic migraine and start to have attacks on more than 15 days per month, then they believe that they have just persistent cognitive dysfunction or persistent brain fog. And they're often concerned that that's going to be a permanent issue. What we know is that if you intervene with migraine therapy effectively, then the cognitive dysfunction will go away. So that's the positive message here, is that what you're experiencing as a consequence of migraine is not a permanent problem. And the reason we know that is because we've actually done cognitive studies on individuals over time to see if even frequent migraine is affecting their cognitive function, and it turns out really that it isn't. So so that's the good news, but it doesn't. But still, recognizing that you have cognitive dysfunction as part of your attacks is in some cases important, and understanding that that's a goal of therapy is basically to treat the whole attack, not just the pain, but all of the symptoms that go with it.
Dr. Young, anything to add?
Just on medications, I am more familiar with the medications that overlap between migraine and depression. For example, the tricyclics, or sometimes when people have both, something that is tried. And some of those medicines can cause cognitive sluggishness. So again, that's not permanent. When the medicine is stopped, that is something that should improve. But that is something to note, if you are on a medicine with that as a side effect and that is impacting your life, then talking to your physician about trying a different medicine that might have less effects on cognition.
Yeah, I wonder how you're able to tether the difference between normal cognitive decline with aging and cognitive issues that are related to migraine. How do you separate those two?
Well, I think, I mean, everyone has issues with, losing your keys and things like that, and it's interesting to how much we hear about that from migraine patients. But I would also say that, if you are actually aware of your cognitive dysfunction, that's actually a pretty good sign, because very often what happens with the more serious causes of memory loss is a lack of an understanding that you actually are having, a problem. And so I often joke with people is that, if there's a one question test for Alzheimer's disease, and that is, do you have a memory problem? And if you say no, then you have Alzheimer's disease, which is obviously a little simplistic, but that, again, that's something that I think is really important, is that awareness that you have a memory issue is actually a very positive sign, and one that sort of can help you tease out migraine related issues compared with something more significant or degenerative. And I would also just echo the point about the medication, that there are multiple medications other than the tricyclics. Topiramate is another one that is commonly used for migraine that can really cause significant cognitive dysfunction. Happy to say that some of our newer approaches don't have cognitive dysfunction as part of it. And then one final point is that sleep disruption is very common with migraine, and issues with sleep can also really contribute to that sense of brain fog. If you're not sleeping regularly, that's something that can really be a big issue in terms of your sense of how well you're thinking.
No doubt, no doubt. And sleep is a huge problem for people with migraine. Dr. Young, I want to come back to a question. You touched upon depression, but depression is so common with migraine. We've got a question here that says, I deal with both migraine and depression. How do I treat them? And should I treat one before the other?
So as we touched on with anxiety, this relationship is really bidirectional. So it's a little chicken and egg. So I think they need to be handled in parallel. And there's no, first or second, but really in parallel. There are, though, some overlap. So just like migraine is complicated and there's biological factors as well as psychological factors like stress that can contribute, as well as lifestyle factors like getting good sleep. All of the same is true for depression. And so there's going to be overlapping things that you can do to help your migraine as well as help your depressive symptoms. So things like getting good sleep, getting in some sort of form of movement if you're feeling well enough that day, eating well, those are all things that are going to help both. Learning to cope with stress, getting those strategies, that's going to help with both. And then, like we talked about a little bit, there's also medications and other interventions that can help both. So there's some evidence that Botox can help comorbid depression that's present with migraine. There's also the SSRIs that, although aren't first line for preventing migraine, can help some people. And then there's the tricyclics, which are used in higher doses in psychiatry, and sometimes the adverse effects make them difficult to use in psychiatry, but that's a medicine that can be used for both. And then the other big thing is cognitive behavioral therapy has been shown to be really helpful for pain as well as depressive symptoms. So there's definitely ways to deal with them in parallel, but then things that you can do that will help both.
Excellent. Yes. Dr. Charles, anything to add?
Yeah, I would just add as a point that while it's true that SSRIs may be helpful for some, and it's really, and it's important because depression, like anxiety, is again comorbid with migraine, so they go hand in hand. So we're commonly having to deal with both. But there certainly are issues with some individuals who take SSRIs, particularly at very high doses. It will actually worsen migraine. And so when we see somebody who comes in to see us who's not doing well, one of our first questions is, did you make any changes in medications that were associated with your worsening? And one of the ones that we've seen just anecdotally, and this isn't really well understood or well publicized, is that the SSRI antidepressants like Prozac, Paxil, Zoloft, in some individuals can really kick up migraine. And so we have to be alert to that possibility. It's sort of like, it's interesting, it's like hormone therapy in that way. For some, exogenous hormone therapy can be helpful, but for others it makes things worse. So it's unfortunately it's complicated, but that's something that I always like to call out, that any medication that you're taking, especially if you made a change in it at a time that you got worse, you should think about whether that medication is a contributing factor.
That's the serotonin syndrome that they talk about?
No, that's not. The serotonin syndrome is something different. That's a kind of life-threatening issue of high serotonin levels that are associated with medications that are targeting serotonin. No, the exacerbation of migraine is something different. We don't really understand the basic mechanism, but it's just something that we see, again, anecdotally.
Great. Well, both depression and migraine, as well as anxiety, are all issues when you're trying to hold down a job. So I'd like to talk a little bit about some of the challenges that people in our community are facing with migraine and work. So one question we have here is from someone who must have a pretty severe case of migraine, who says, I don't feel like I can hold down a full-time job anymore, but I need the benefits in healthcare. What are my options? Dr. Charles, you want to suggest some things?
Yeah, this is a tough issue, and there's obviously multiple examples of jobs that are very challenging. Especially shift workers, for example. It's a huge problem for migraine, but even other jobs in which there are conditions or the lack of accommodation for when one has a migraine attack that make it very challenging. But as we talked about earlier, and as the questioner brought up, it's just often not feasible to find another job, and so our strategies really are to try and figure out how to have people develop accommodations within the workplace that enable them to function at the best level that they can, but also maintain, a state of health that prevents them from really being, more disabled as a consequence of their job. There's not a really easy answer to it, unfortunately. But one of the things we're doing as advocates for migraine is really trying to talk to employers and make them understand that this is an extraordinarily common disease that is affecting people's ability to function at the workplace. And that's something that needs to be recognized by employers in order to really get the most of their workers.
I agree. This is something that is very personal for me. It was one of the biggest challenges that I have faced with migraine in trying to hold down a pretty demanding job and manage migraine. And like many people, you can start, I started by trying to take a leave of absence and then shifting down to part-time work for a period of time just so I could get my health back in order. And that's one of the things we talk about a lot on migraineagain.com. And you can see many articles there. I should also point out that in the Facebook live chat, you're going to see some references to different articles that might help to answer these questions more fully. And we encourage you to go and check those things out and find some of the answers that you may be needing that we don't have time to fully address here today, because this is a huge, huge challenge. A question for you, Dr. Young. My boss seems to think that I'm faking it when I have to go home early due to a migraine. He thinks migraine will just go away with an aspirin. What do I do?
This one's really tricky, right? How do you get people to understand? I think this is a challenge for any chronic illness, but especially the chronic illnesses where there's no visible sign, right? Headache, depression. There's a lot of illnesses people have where you don't physically look ill, but you are. And so I think it's kind of twofold. There's a lot of great work going on, like you're doing, to increase awareness around this issue, and hopefully people can maybe have some resources to share with their boss to help them understand. I think the other thing, though, that becomes important, though, is more personal work, which is setting the boundaries that are important for your health and being assertive, kindly and respectfully assertive about it, and sticking to them. And if someone's not able to understand that, that's a them problem, not a you problem. And I think that people don't realize it, but this is a really challenging skill, to be able to set a boundary and be respectfully assertive about it. And it's actually something that you can learn in therapy, a very practical skill. Therapy doesn't have to be, what a lot of people think of, talking about your childhood. Sometimes it's about very practical skills, and this is one of them. And so I think that can be helpful too, to kind of separate what's the you problem, what's the them problem, and then being able to set that boundary.
That's very well said. So another question that came up, Dr. Charles, kind of references one of the hallmarks of migraine versus other types of headaches, which is light sensitivity. And someone asked, they said, my job requires me to look at a computer screen for several hours a day, which is really hard with migraine light sensitivity. What can I do?
Yeah, well, so that's another question that we hear all of the time. And some people really think that it's specific to a computer screen, whereas more commonly it's just light of all kinds. But certainly some wavelengths of light can be more problematic for people than others, and that's where Sometimes wearing glasses that filter out certain wavelengths can be helpful for some, not all. But then in terms of other issues, we think about like not just the intensity of light, but the contrast, what's the background? Is it bright light against a dark background? For many, that's more visually uncomfortable than just if it's a much more uniform light intensity throughout the room, and then the computer isn't really standing out against that. There's not any honestly single answer that I can give to that question. It really is a lot of trial and error, and having people play around with light intensities, with background light, with wavelengths of light to see if there's anything adjustment that they can make easily that will be able to address that. The other kind of interesting issue, though, is whether light sensitivity is something that is made worse by avoiding light. And so very often we have people with migraine coming into our office, wearing dark sunglasses, and we get a sense that those people are really now so sensitized to light, partly because they're never exposed to it except for when they take their sunglasses off, that then that becomes actually more of a problem than if they were actually exposing themselves more broadly to the light. And so it's a controversial topic, but there's some of us who actually believe that kind of training yourself and gradually becoming accommodated to brighter light is something that is better than hiding from the light with sunglasses.
I have found another thing that helps is using filters for the screen, as well as glasses that can filter some of that light personally. So lots of options to manage it. And light sensitivity is something that that escalates the more chronic you become. So I want to pivot and talk a little bit more about chronic migraine, because migraine is a spectrum disorder. It affects some people at a very mild level, but I suspect that many of the people who are with us today have chronic migraine more than half the days of the month. So here are a couple of questions that are related specifically to chronic migraine that may be useful for people who also have episodic migraine. So Nancy is asking, why can't I find a way to not have daily chronic migraines? I have been to all the different neurologists and doctors for 30 years and nothing helps. Dr. Charles, I suspect you have many people in your practice who have exactly this story.
Yeah, well, fortunately not that many, because we're actually able to help quite a good percentage of our patients, especially with the newer therapies. But one of the ways we think about it is that migraine is a problem of the brain where certain parts of the brain become switched on. And when you have episodic migraine, they're switched on transiently. But when you have chronic migraine, they just get switched on and they stay on. And there's a sort of a different set of problems that occur when you have chronic migraine. And so you have to intervene in different ways. What I would say to the questioner is to really think about coming after it from every single angle that you can. So we have our new therapies that for some are spectacularly effective, not for everybody, but with our newer therapies, we can even take people who have been at it for 30 or 40 years and really turn them around, believe it or not. But oftentimes, this is a case where other therapeutic approaches like cognitive behavioral therapy, for example, can be very helpful in trying to switch off some of those switched on brain areas that aren't going to be necessarily targeted by medications. And so here again, your situation is one where we would really want an absolutely multidisciplinary approach with lifestyle approaches, medications, different sorts of behavioral approaches, attention to pretty much everything you can think of to try and intervene and bring down that level of headache that is with you all the time, and with the goal being to get it back to being episodic.
And I do want to talk about lifestyle as well as some of the new treatments that you mentioned when we come up and talk about treatments. But for right now, as we're managing chronic migraine and its sort of intersection with some of the mental health things, I want to talk about behavioral therapies a little bit more. You mentioned CBT, which has good evidence for migraine. What about, and this is really for both of you, what about biofeedback or mindfulness or meditation? What do you think about those therapies for migraine?
You want to go with that one, Dr. Young?
Sure. So I think that mindfulness can be a powerful tool, perhaps not to manage directly the symptom of migraine, although it can help as a coping strategy for some of the other things we talked about that can help trigger migraine. But I also think what gets difficult with a chronic illness, or really any chronic stress that's present for a long time, is we have our primary emotional response to that, but then we have this sort of secondary narrative we tell ourselves. So if we sort of feel like we missed out on an opportunity or we aren't engaging in life the way we want to because we have this chronic migraine, then we might have this initial sadness, but then we're going to pile on to that sadness by telling ourselves the story of the past things we missed out on, what kind of future things will we mess up. Now I'm having a pity party for myself and I feel kind of bad that I'm having a pity party, and it spirals. And I think what mindfulness can help with is help you kind of non-judgmentally observe, okay, I'm feeling sad, I'm feeling disappointed, and not add on to that. But then I also think it can help tune in, so when you are having a good day where you're not having migraines, you're able to fully engage in that day without having that thought, oh, when's my next migraine going to come? So when you're having a bad day, you're kind of letting yourself compassionately manage that bad day. When you're having a good day, you're fully engaged. So I do think it can be helpful to manage the illness as a whole, perhaps not individual specific symptoms of it.
And
Yeah, I would agree. I think it's interesting because I have talked to people who try to do mindfulness approaches during acute attacks. And, you know, one of the mindfulness approaches is to do a body check, for example. And so I had a woman coming in the other day and she said, yeah, I did a body check. Yeah, my head hurt, my eyes hurt, my stomach hurts, my legs hurt. You know, I'm nauseated, and that was her body check. So, you know, it really is something that you have to, as I totally agree, use to manage the disease in appropriate ways and often preventively, rather than trying to do it, you know, as something that will take away symptoms of an individual attack.
And I'm glad you mentioned that full body check, because it's a great reminder to us that migraine is so much more than just a headache. You know, the symptoms that ravage your entire body, from, you know, disabling nausea to cold hands and feet and sometimes numbness, all the crazy things. Neck pain is one that comes up that nobody talks about very often. Dr. Charles, can you just address neck pain pretty quickly? And then we're going to move on to another topic.
Sure. So it's important to recognize that neck pain is a symptom of migraine. So more than 50% of those with migraine have neck pain as part of their migraine attack. And it's not necessarily a cause. People very often think it's a cause. They often walk into my office with a scan with some little disc bulge or bone spur and say, see, this is what's causing my migraine. And no, it isn't. It's that neck pain happens as a consequence of a migraine attack. And we're beginning actually to understand the anatomy of that. At UCLA, we're doing some work showing that the neck nerves are very, very important as a sort of pathway for transmission of migraine pain. So what we always tell people who are focused on neck pain as a cause is, let's treat your migraine, get your migraine under control. And very often people are quite surprised at the fact that their neck pain basically goes away if we're able to effectively manage the migraine.
That's well said. And, you know, there are so many incredible questions about chronic migraine that I really want to answer, but we don't have time today. So I'm just going to remind everybody that Dr. Charles has answered hundreds of questions hundreds of questions in the Ask the Headache Specialist segment on migraineagain.com. So you go to the homepage of migraineagain.com, you'll see everything there, and you can look up any question that you might have, and he's probably answered it. And if he hasn't, email me and we will get it under his nose to take a look at. So one of the things that comes up with migraine in relationships is this stigma where people don't understand. They say, and so we have a question, how do you talk to people that think it's just a headache? What's the right way to respond to those kinds of things, Dr. Young?
So this goes back a little bit to what we talked about with the boss, right? There's some people that don't know what it's like to live with a chronic illness and aren't able to, even if they can't imagine what it's like, provide that kind of empathy and compassion. So going back to that answer, that's kind of a them problem, not a you problem. And I think it gets really difficult because I know a lot of people where their chronic illness put a strain on relationship. But again, you have to trust that you're doing your best. And if somebody isn't able to understand that that's not a reflection of you, that's a reflection on them. You can do your best to tell them and do your best to educate them on what you're experiencing. But ultimately, unfortunately, we can't force people to get it, and we can't force people to be compassionate about it.
Each of these opportunities is a way to educate people little by little, but sometimes you just have to let those relationships go and move on. If they, if you had some other disabling disease or disorder and they didn't understand it, you would leave. So it goes back to what Dr. Charles was saying, is don't blame yourself. It's a them problem, right?
Definitely, definitely. And I think just because you might not have found the safe people yet that are understanding, it doesn't mean they're not out there. There are plenty of people who are going to understand and be able to be in your life despite this. So if you haven't found them yet, they're out there. You'll find them.
That's right. They're out there, and you can find a lot of them on migraineagain.com as well as the Daily Migraine, our social network. So I'd like to move on to migraine and treatments, because a lot of people are here to hear about the new treatments that are available to us today that we didn't have just a few years ago. So Dr. Charles, can you talk a little bit about what medication is available to help today that we didn't have so long ago?
Yeah, so our most exciting new therapies are ones targeting this a chemical called CGRP, which stands for calcitonin gene-related peptide. And one of the reasons that we're so excited about this is that it really was, for the first time ever, built on a solid foundation of research. I mean, most of the therapies that we've used for migraine traditionally have been ones that we've borrowed from other indications, like depression or seizures or blood pressure medications. But this is specifically developed for migraine, and that's something that just conceptually is very important. The notion that we can actually now identify mechanisms of migraine and develop treatments for them. So even if you're not responding to these new therapies, you should have hope based on the fact that we are now able to target mechanisms much more definitively than we had in the past. So going back to these, the CGRP therapies, there are the first that were available were these what are called monoclonal antibodies targeting CGRP, and then we also have now the traditional tablets targeting CGRP. For some individuals, these are absolutely spectacularly effective. Unfortunately, not for everybody, but we have people who, as I mentioned, have had migraine for 30, 40 years, tried everything under the sun, never had any benefit, and still respond to these. So if you haven't tried them and you're struggling with migraine, absolutely you should try one of these new therapies. So that's one element. And then we have some others that are basically modifications of previous therapies. So there's a treatment called lasmiditan that is like a triptan. It's like sumatriptan or rizatriptan, but it doesn't have any effects on blood vessels. And it also seems to penetrate the brain more. So it may work very differently than the triptans for some individuals. So those are those approaches are some of examples of the new ones. There are also new delivery methods of some of our previous therapies. So there are new intranasal preparations that are looking quite interesting because they're absorbed better through the nose. And there are some other new ways of delivering treatments that are looking exciting as well. So basically, even just over the last 5 years, I'd say, we have probably 10 new different treatments that we have to offer individuals in the realm of medications that can, in some cases, really be game changers for individuals.
And we're seeing that a lot in our community too. So thank you for highlighting some of those. We've got a few questions about supplements, and people are interested to know, are there any supplements that are proven to help prevent migraine? And in particular, questions about magnesium. Does it work? Can you take these along with some of the medications or in place of them? Dr. Charles?
Yeah, so the evidence, unfortunately, is really weak. There really isn't strong evidence for any of the supplements. Probably the best evidence is for CoQ10, where there are a couple of studies from Switzerland that showed benefit. There was also one study on riboflavin, vitamin B2, that was reasonably done. But I have to say that in general, there's very little evidential support for these therapies. And in our clinical practice, I have to say, I put these in the category of the kind of why not sort of therapies. They're naturally produced, they're occurring in your body. They, generally speaking, don't have significant side effects, although with magnesium, you can certainly have significant gastrointestinal adverse effects. But generally speaking, they're pretty well tolerated. And so, of the ones that we recommend, magnesium, riboflavin, CoQ10, and sometimes melatonin, we will often give those, but typically not as a primary therapy. Generally speaking, we're using them as adjunctive therapies to try and help other therapies work better. But I have to say, after 30 years in practice, it really isn't something where I've seen, generally speaking, really miraculous responses to these where they are the only thing that people can take to be able to control their migraine.
That's great. And there's a ton of information about these supplements on Everyday Health as well. To find all the information about migraine and supplements and different treatments is widely available on everydayhealth.com. So we only have time for a few more questions, unfortunately. We're running out of time, but I encourage people to go and search for these questions on everydayhealth.com as well as migraineagain.com to find what you're looking for. And if you don't find what you're looking for, email us and we will add it into our editorial calendar coming down the line. So another question really for both of you is, if someone has tried their treatments and maybe they've been on a course of treatment, a preventive treatment, and it stops working, they may feel desperate, like they're out of options. Ramona says, what happens when all the treatments stop working? Does a pain clinic have any tricks up its sleeve, or what options do I have? Dr. Young, how would you counsel Ramona?
So I think a couple of things. One, like we touched on, there's new treatments that are emerging and coming out. And so I think it's a time to be hopeful and not lose hope. And then, like we said, this is a multifaceted disorder. And so one avenue maybe won't be working for whatever reason, and then we're going to look at all the other ones to help address those while we fix the other. And so I think just being proactive and doing the best we can with the many different aspects that make up this disorder. And there's reason to be hopeful.
Dr. Charles?
Yeah, well, I would say also, and this is, I have a little bit of a biased perspective, but unfortunately, the sort of general pain physicians don't have anything particular to offer that migraine specialists don't have. And the reason that I bring that up, and not to be negative about pain physicians, but it's just that if you start to implement non-specific pain approaches, particularly things like opioids, that can be incredibly problematic and sustain migraine and worsen migraine over time. So most headache specialists are trained in doing interventional procedures like nerve blocks or botulinum toxin injections, things like that. Whereas the things that you would go beyond to a pain clinic, where they're doing more like facet joint blocks or other more invasive procedures. Generally speaking, those are not ones that are particularly helpful for migraine. And people with migraine become desperate and seek out what are pitched as more definitive therapies, including other even surgical procedures to try and help with the problem. But unfortunately, really that's it's very, very uncommon for those to be particularly helpful. And so, my point would be to be hopeful that, now that we actually have a better understanding of the specific causes of migraine, that, even if you haven't responded to anything yet, which I think is almost never true. I don't think I've ever seen anyone who had tried every single thing that I had to suggest. So keep trying, keep talking to people about what therapies are available, and be hopeful that the current research is continuously identifying new targets and new approaches, and try not to fall prey to people who are basically taking advantage of people who are desperate and doing things that really aren't going to be helpful.
Yeah, just to piggyback on that, because I didn't understand when answering the question, the specific pain doctor aspect. And I agree. I think seeing a specialist that can give you, and this is for mental health as well as for migraine
Yes.
or any chronic illness, that is able to weigh out the risks and benefits of the
Yes.
specific treatments and help you make a decision in your care with you as a partner is essential. If you're going to see anyone, whether it's a traditional conventional medical doctor or a chiropractor, an alternative medicine doctor, a functional medicine doctor, whoever it is, if they're giving you something curative and telling you it's curative and not weighing the risks and the benefits with you, that's a red flag. And
Yep.
I would reconsider immediately, because your discussions with your healthcare provider should all be risks, benefits, and making a decision together.
Yep.
Well said. So there is no cure, but there is help and many reasons to be hopeful about the opportunities for migraine. Great. Well, that's actually all that we have time for today. So many great questions from the community, and we're deeply appreciative to you, Dr. Charles, and to you, Dr. Young, for sharing your expertise with our community. You asked and they answered, and millions of people are benefiting. So if you know someone who needs to hear some of the valuable insights that they've offered today, please share this webinar in social media or email or whatever your medium is. And that's what Migraine and Headache Awareness Month is all about. And for more, we want you to check out all the resources on everydayhealth.com, and don't miss the Ask the Headache Specialist question and answers on migraineagain.com. And if you need to find a doctor who's qualified to treat you, check out Castle Conley's Top Doctors to find someone in your area. That's topdoctors.com. And if you're looking for people who truly understand what you're going through, join our team of patient advocates who lead Migraine Again and the Daily Migraine, because we are here to help you. So in closing, I'm Paula Dumas, wishing you a better health today and every day.